Hello, everybody. We're going to start this section, this important section, Symposium from MicroPort, leading with evidence, choosing with confidence. It's an important symposium. We have a well-known physician, experts, that will talk about the TAVR procedure and also coronary procedure in this session. First of all, I'd like to thank this kind invitation from William. Thank you, William, for me to be the moderator of this session. Before I start really the session, I'd like to give the word for William to say some words from MicroPort and to show us also a video. Isn't it, William?
That is correct, Dr. Mangione. So thank you very much, Dr. Mangione, and buenas noches, boa noite, good evening, and for some of the participants, good morning, and welcome to this last activity of the SOLACI-CACI Congress, which is our MicroPort Symposium, where we are going to share with you some experiences with two our products, actually our TAVI and also our drug-eluting stent Firehawk, which are part of our broad portfolio of products. MicroPort is a company that has products across 12 therapeutic areas, and we are bringing them now to Latin America. You will see us in the different countries, structuring operations, reaching out to the physician community in the very near future. Yes. So with this, I would like to share with you a brief video that describes MicroPort, which is a player that is arriving now to the interventional cardiology arena in Latin America.
MicroPort Scientific traces its origin back to 1998. We're a group of dedicated individuals joined together at a small office at Junjie Zhang high-tech park of Shanghai to transform medical treatments and enhance patient outcomes. Through years of growth and innovation, MicroPort is now a leading multinational medical solution provider, including cardiovascular intervention and structural heart, electrophysiology and cardiac rhythm management, orthopedics and soft tissue repair, endovascular and peripheral vascular diseases, neurovascular intervention and neurosciences, life sciences, urology and gynecology, respiratory and gastroenterology, surgical devices and medical robotics. With over 300 products currently approved for use globally, MicroPort is contributing to a better world through its life-saving medical therapies and quality-improving care. MicroPort devices are being used in patients every 6 seconds to help save a life, improve quality of life, or create a new life for tens of millions of patients worldwide. We currently have a global workforce of over 7,000 employees from over 30 countries. At MicroPort, we're always enthusiastic and passionate about maintaining the highest standards of quality in all aspects of daily operation of our business, because we believe it takes hundreds of millions of small details to achieve one triumphant success. MicroPort has created a unique management concept named Integrated Horizontal and Vertical Organization Management Model. The main vertical functional departments, supported by horizontal club-like organization. This innovation concept targets to break department silos, promote cross-departmental cooperation. At MicroPort, we are committed to our corporate social responsibilities, are constantly seeking new ways to improve the well-being of people and local communities. MicroPort is committed to become a people-centric enterprise that is dedicated to deliver a wide variety of emerging medical technologies and ultimately to improve and reshape human lives. MicroPort scientific.
Okay, so this is a very brief description of MicroPort. MicroPort has a global footprint. It is really a multinational company that from Asia, where the headquarters are located, we are expanding both to America and Europe, across 80 countries and regions, reaching out already to more than 10,000 hospitals. So in our region, Latin America, we are going basically to continue our journey with the MicroPort Life Triangle, where the patient always comes first, and together with the physician community, who is very well represented here tonight, we want to really support the care that you provide to the patients. So as we speak, you saw in the map that we have the Brazil operation, and we are opening up actually the Colombia operation next week, and we will be a lot closer to the medical community and the patients. We are very committed to right now support the physicians, the institutions in their care of the patients, especially in a critical moment where Latin America, that is the continent that was hit the hardest with COVID, starts finding its way out of the pandemic. So we will be there supporting the physicians, the institutions, your practice, while expanding the access of the general population to the therapies. So as the Vice President for Latin America for MicroPort, I really want to thank you again, Dr. Mangione, for being the chairman of this session. Thank you also to our panelists, Dr. Abizaid, Dr. Sztejfman, and also to our speakers, Dr. Lansky, Dr. Song, and Dr. Zhang. So with that, Dr. Mangione, I will transfer it back to you.
Thank you, William. Thank you for this nice presentation of your company that is growing so fast in the field of interventional cardiology. Congratulations. Before we start this meeting, I'd like also to present our panelists, two experts, panelists in interventional cardiology. The first one is Dr. Alexandre Abizaid. It's my friend here from São Paulo, Brazil. Dr. Alexandre is a technical director of invasive cardiology in Instituto do Coração, the Heart Institute here in São Paulo. And he is also physician in interventional cardiology of the Heart Hospital in São Paulo, two very well-known institutions here in Brazil. It's a pleasure, Dr. Alexandre, to have you with us in this meeting. Thank you. And I'd like also to introduce Dr. Matias from Argentina. Dr. Matias works in the Sanatorio Gemes de Buenos Aires. He is also director of the structural program at Sanatorio Gemes and the Sanatorio Finocchieto in Buenos Aires. Also, thank you for your participation to take part of this meeting with us, Matias and Alexandre. We're going to change we are going to do a little change in the program of this meeting for a real reason, because Dr. Alexandra Lansky is spending her vacation in France, and now in France is 2 o'clock in the morning. So I'm going to change the program. The first speaker is going to be Dr. Alexandra. Dr. Alexandra, you talk about the 4-year, the target AC trial, 4 years results of this all-comers trial. So, Dr. Alexandra, the word is yours. Feel free to make your presentation. Thank you for your presence with us.
Well, thank you so much. I want to really thank you for agreeing to switch around the schedule. And yes, so I'm going to be talking about the target all comers trial and presenting to you the 4-year results. And it's really my pleasure to do this on behalf of many investigators in the steering committee for this clinical program. Here are my potential conflicts of interest. And I'll start this off just talking a little bit about the device. This is an abluminal groove-filled biodegradable polymer that targets the release of sirolimus. So you can see that this is a thin strut cobalt chrome platform, strut thickness of 86 microns, with these abluminal grooves that contain DLPLA bioabsorbable polymer, and contains the sirolimus at a dose of 0.3 micrograms per millimeter squared. And as you can see here, the release is about 90% release at 90 days. So it's very targeted and minimum dose of sirolimus. So the trial design is here for target all comers. This was an open label non-inferiority trial. Really minimum exclusion criteria. There was no lesion or vessel limitations. And you can see it was a 1-to-1 randomized study of 1,656 patients enrolled at 20 sites in Europe. You can look at the flow here of the trial. There was an OCT sub-study here in 50 patients at 3 months, and an angiographic sub-study at 13 months. And our primary endpoint, as is traditional in these studies, was at 12 months. So the primary endpoint was target lesion failure, defined using traditional definitions, including a composite of cardiovascular death, target vessel MI, and ischemia-driven target lesion vascularization at 12 months. And again, 2 powered secondary endpoints, an in-stent late lumen loss at 13 months after the clinical endpoint, and neointimal thickness at 3 months based on OCT. Now, importantly, the dual antiplatelet therapy was based on guidelines and really at operators' discretion. I should point out that this trial was very well conducted. You can see many well-recognized institutions. Cardialysis did the statistics. There were core labs, Data Safety Monitoring Board. Harvard did the clinical event committee. So really very high-level trial conduct. Here, the statistical assumptions and the patient flow. Just to go through the patient flow here, again, 1,653 patients. You can see at 1 year, we had 96% follow-up. And when you follow patients out to 4 years, we had about 94% follow-up in both groups. Again, very good for this kind of study. And then in terms of the statistical assumptions, we had 85% power in this study to demonstrate non-inferiority in the primary endpoint at 12 months. Our assumptions were that the control event rate in terms of target lesion failure was 7%. We had a non-inferiority margin of 3.5%, and assumed that we would lose about 5% of patients at 12 months. So high level, here are some of the demographics and lesion characteristics. I think they're pretty typical of an all-comers patient population. As you can see here, just things to highlight, we had just short of 10% ST elevation myocardial infarction patients in this study, mostly smaller vessels, less than 3 millimeters, long lesions. Only about 20% had multiple vessels treated. You can see that the vast majority of patients had complex lesions, so B2C lesions in more than 80% of patients. And then low numbers here of in-stent restenosis, total occlusions just shy of 10%, bifurcations requiring 2-stent strategy about 20%, and low rates here by core lab of severe calcification. Just wanted to show you and remind you of the angiographic results. So again, this was based on late lumen loss in stent, designed for non-inferiority, and we met that endpoint. So you can see that the late lumen loss here was 0.17, it was non-inferior to Xience based on the assumptions. And then the OCT endpoint, again, we're looking at neointimal thickness here, met that endpoint as well, is slightly lower with the Firehawk compared to Xience. And importantly, when we looked at strut coverage at 3 months, it was 99.9% compared to 100% with Xience. So again, meeting non-inferiority for this endpoint. So we presented and published the primary endpoint at 12 months. You can see just based on these Kaplan-Meier curves of target lesion failure that there was really no difference out to 12 months, and beyond that to 24 months, we met non-inferiority. And here's the landmark analysis, again, showing the outcomes out to 12 months and then beyond 12 months to 24 months, with these curves essentially superimposed on each other. So really very good, reliable performance in terms of target lesion failure. So now I'm taking your results here out to 4 years. Again, this is our primary endpoint, but you can see absolutely no difference in these outcomes, numerically favoring Firehawk, but not significant out to 4 years. These are the rates overall and the components of that primary endpoint. So you can see target lesion failure was about 14%, target vessel failure 16%. I think this is interesting. The major adverse cardiac events was 25%, more or less, not different between the two groups. I think representing the high risk of an all-comers patient population. And then mortality, cardiac death, myocardial infarction, etc. None of these were different out to 4 years. Now looking here at the 4-year outcomes in terms of revascularization, again, if you look at the overall revascularization rates, they were quite high, 17%. I think that represents the complexity of the patient population. But importantly for the device, ischemia-driven target lesion revascularization was less than 5% in 4 years. So that is really outstanding results. And again, no significant difference favored the Firehawk device. Here's stent thrombosis. So looking at the safety outcomes out to 4 years, I'm displaying this on an annual basis. We're looking at definite and probable stent thrombosis. What is interesting to see here is while there's no significant difference at any one of these time points, you can see that numerically we're seeing more definite stent thrombosis with the Xience compared to the Firehawk. So potentially, if we take this out to 5 years, this may become significant, but at least numerically. And here we're looking at very late stent thrombosis at 4 years. Again, no significant difference, but numerically better for the Firehawk. And here are the numbers and the actual differences between the groups. So again, here just looking at the Kaplan-Meier estimates of all the primary endpoint and the components, once again showing absolutely no difference between the groups. I wanted to show very briefly a sub-study that we did based on dual antiplatelet therapy. You can see that in stable patients, there was discontinuation of DAPT here at 6 months and then again at 1 year. And in the ACS patient population, most discontinued at 1 year. And still there was about 25% with still on dual antiplatelet therapy at 2 years. And what I'm showing you here are the outcomes based on device after discontinuation. And while there's no significant differences here in any of these endpoints, you can see that there are trends favoring Firehawk here in terms of target vessel MI and ischemia-driven target lesion vascularization. So just to conclude, I think this very important study in an all-comers patient population, I think first of all, Firehawk met all the safety and efficacy endpoints of the science at 12 months. It maintained those outcomes out to 4 years. We had very low ischemia-driven target lesion vascularization rates at 4 years. I think in the patients that discontinued DAPT, at least at 2 years, we saw trends for a safer performance with Firehawk compared to Science, at least trends. And just to state here that we will be presenting the 5-year final results at PCR next year. So May of next year, you can expect to see the very final results. So that's all I have. Thank you.
Thank you, Dr. Alexandra. It's a nice presentation of this trial, important trial, all-comers trials, comparing Firehawk with we can say gold standard of stents, Verolens stent science, and showing good results in an all-comers population with some adverse characteristics, calcification, almost 40% of the patient in acute coronary syndrome. So very high risk population, we can say. I'm sure that our panelists would like to make some comments, some questions for Dr. Alexandra, Dr. Abizaid, Dr. Matias. Feel free to make your comments and questions.
Thank you, Mangione. First of all, I know Alexandra for the past, I think, 25 years. We did our fellowship together in Washington. And since then, Alexandra has been giving great contributions to our field. She's a great scientist, a great trialist. And again, thank you so much for one more important publication with close to 2,000 patients to introduce a new DS, which is great for our community. Now, my question to you, Alexandra, is when we are talking about a novel, a drug-eluting stent, we always see the safety feature. There is no doubt that this stent is very competitive with very last or latest generation features, such as low, very small strut thickness, a ligous drug with a very advanced polymer technology. But my question to you is that, of course, you need to design a study like that, a pivotal trial to show non-inferiority. But what comes next? We always seek for short DAPT. Do you think that this stent will perform well if you have to stop doing antiplatelet therapy early on, and particularly for those patients with high risk for bleeding, but with acute coronary syndrome? Do you think they were ready to push a little bit the envelope in a new device like that for short DAPT in high-risk patients?
Yeah, thank you, Alex. And, I have to also say that, we worked 25 years, it was longer than 25 years ago as fellows, and it's just wonderful to be here together with you. I think with respect to your question, the all-comers patient population obviously is pushing the envelope in terms of challenging the device. And I think the results of this study are important because we're showing that in this highly complex patient population with a high proportion of patients with acute coronary syndromes, we are seeing patients. And, we'll have to wait and see what those results are. But my, from all the information we have so far, whether it be the OCT results where we're seeing, excellent coverage early on, we're seeing numerically lower rates of stent thrombosis, very late stent thrombosis with Firehawk compared with the standard. I mean, Science is truly the standard stent that we use in clinical practice. So I would say, yes, we are ready to push to reduce DAPT with this device, but like with anything else, we're going to have to test it first. and really look at the high bleeding risk patient population, etc. And again, those trials are currently ongoing. So the results will be out pretty soon, I think.
Thank you.
Okay. Thanks, Dr. Matias. Yes, you'd like to make some comments?
Yes. Thank you, Jose. I have a question for Alexandre. The question is, some events was higher in both devices, like revascularization. So my question is, what is the analysis about these higher events than others, other trials? You mentioned that there was a high rate of complex lesions, but also I would like to know what was the rate of vascular ultrasound use in all this population.
So, I think that's a very good question. So I think that your comment has to do with the overall rates when we look at the patient-related outcomes. 25% of patients actually had a major adverse event at 4 years. So that, is relatively high. If you go back and you look at similar all-comers patient population, it's comparable to what we've seen in those patients. And what that tells us is that we have an all-comers cohort here. These are high risk, they have multivessel disease, and they have progression. I think the key thing comes down to trial design and the whole adjudication of events. I think the important thing related to this device is that when you look at the target lesion per se, and you look at ischemia-driven revascularization, the rates are extremely low, so they're less than 5%. So, I think what we're looking at here is a high risk cohort of patients. Excellent performance of the device. In terms of the intravascular ultrasound, I went back to look to see if we had collected that, and I couldn't actually find the proportion of patients with IVUS, so I can't address that question. But I think there's no question that I think it's a signal that tells us that we're really looking at a high-risk patient population when you look at the overall MACE.
Okay, I think it's time for Dr. Alexandra leave the meeting. Okay, you really deserve some rest. 2 o'clock in the morning in your vacation. Okay, enjoy your vacation, Dr. Alexandra. Thank you for your presence and this beautiful presentation. Thank you very much. Okay.
So much. Thank you.
Bye-bye. Bye-bye. Okay. So let's continue. Let's continue our section, our meeting. And now is a very interesting topic about TAVR. So Dr. Guangyuan Song, you're going to present the 4-year clinical outcomes of VitaFlow transcatheter aortic valve system in patients with severe aortic stenosis. Dr. Zhang works in Beijing Hospital, Capital Medical University. He is also professor and director of Interventional Valvular Disease Center. Okay, Dr. Song, it's a pleasure to be with us, to have you with us, and please feel free to make your presentation.
Yeah, thank you, Professor Mangione. It's my pleasure, to be invited to your meeting. So I'm going to report the 4-year clinical outcomes of MicroPort VitaFlow TAVR system in patients with severe AS. I'm going to introduce in 4 aspects. So let's say the device first. This is bovine pericardial leaflets with double PT skirts, inner and outer skirts. And also this is a self-expanding valve, just like portico design. We can see the large cells on the top and the high density cells on the basic. VitaFlow has full size, it's 21, 24, 27, and 30 millimeters to be used to different aortic stenosis sizing. So the most specific for this valve, I think, is electronic mode to deploy, the valve very stable and very accurate during the deployment. So this is a motorized handle, and the profile for this delivery system is 16 and 18 French. I think VitaFlow registry, this is a second registry in China. This is a prospective multi-center and single-arm trial. The trial enrolled 110 patients. All patients was followed up at 30 days, 6 months, 1 year to 5 years per year post-TAVR. All-cause mortality was a primary endpoint at 12 months. The second endpoint is device success, procedure success, major stroke, valve performance, improvement of heart function, MIS, and improvement of life quality. So among these 110 patients included in this trial, the mean age is 77 years old, and all patients, I think, is a high-risk patient for TAVR. And this trial included 38% of bicuspid aortic valve in this study. This is a traditional Chinese morphology because, our patients is younger, I think, than Western countries. So maybe that's the reason why we have more bicuspid valve in China. And also in the first trial, the winners trial in China, we also included 44% of bicuspid valve in the study. This is absolutely severe aortic stenosis. The orifice, I think, is 0.6, and the mean AV gradients is over 60. 94% of patients was performed TAVR from the transfemoral access, and 5% from transcarotid access, and 1% was ascending aorta. Because the subclavian artery is relatively, small in China, so that's the reason why we use more carotid and ascending aorta access for TAVR. The most popular size in this study is 24 millimeters. The second one is 27 millimeters. And the 4% we use 30 millimeter size, and 7% we use 21 millimeter size. From the hemodynamic follow-up, we can see during the 12 months follow-up, the performance of VitaFlow valve looks very good. The main orifice is 1.8 during the 12 months follow-up. And the main gradients from the VitaFlow is less than 10 millimeters mercury. There's no moderate and severe PVL at 1 year follow-up. You can see when we perform the 30-day follow-up, there's 2% of moderate PVL, but during the 12 months, there's no PVL during the 12 months follow-up. So 1 year mortality looks very good. Also, this patient is high risk. All-cause mortality is only 2.7%. So cardiovascular mortality is on 1.8%. All stroke is 4.5, there is no major stroke during the 1 year follow-up. The major vascular complication is 2.7. However, VitaFlow has, the permanent pacemaker implantation is almost 20%. I think this is because, this is only the second registry for TAVR in China, and most centers are in the learning curve. So you can see 6 patients with only 1 degree AV block was implanted by with pacemaker. So I think that's the reason why they have such a high pacemaker risk. During the 4-year follow-up, all-cause mortality is 12.7. The cardiovascular mortality is 7.2%. The major stroke is 1.8, and also the new pacemaker is 20%. So we have 100% follow-up during the 4-year follow-up. So conclusion, VitaFlow, the new designed electronic mode TAVR system has good hemodynamic results at 1 year follow-up. It has low all-cause mortality and cardiovascular mortality rates at 1 year follow-up. And all-cause mortality rates at 4-year follow-up is 12.7. The cardiovascular mortality rate is 7.2. So the 4-year clinical outcomes support, the safety and efficacy of VitaFlow in the treatment of patients with severe AS. So I'm going to report one case. I know Professor Zhang will present a traditional VitaFlow case. So I'm going to go very quickly with a classic case with VitaFlow. This is 79 years old male with severe aortic stenosis. The ejection fraction is normal. So this is sizing, and also we can see the sinus. This is function, a bicuspid valve with left and right fusion, calcium concentrated in the non-coronary sinus. And we can see the long strips of calcium extending from the supraannular to the anterior mitral leaflet. This is sizing. We always use the multi-planar measurement from my center. So we can see from the aortic to the supraannular level, every 2 millimeters, we tracing, for the sizing consideration. So this is like a tube-like, area to seal and to anchor the valve. So this is the one I want to mention. The idea is from Matias. He used accurate nail too, the all-in-one technique. So I tried, to use the 20 French sheaths with all-in-one artery technique. We can go very smoothly with 20 French core sheaths with a 5 French pigtail and the VitaFlow delivery system. The other one I want to show is not this. We always perform angio before the TAVR procedure. The other one I want to show is the position of VitaFlow. The classic, the positioning for VitaFlow is like this. It's already 0 positioning or even a minus positioning for VitaFlow to reduce, the PVL. That's why, the reason there's no moderate and severe PVL during the 4-year follow-up. Yeah. So this is the echo. Thank you very much for your attention.
Thank you, Dr. Song, for your presentation. It's a very interesting device, a new device, a self-expanding device with a supraannular position and with a skirt in the base of the valve so to avoid the paravalvular leak.
Yeah,
and you showed only 2% of moderate paravalvular leak, so a very low incidence of moderate paravalvular leak. So I'd like to also to hear some comments again of our panelists. Let's start with Dr. Matias. Dr. Matias, you have some questions, some comments about this new device of TAVR?
Yes, thank you, José, and congratulations, Dr. Zhang, for the presentation. And also, I am impressed that do you use the all-in-one or single puncture technique. So this will be my second question, and it's about how did you feel it, the pigtail inside of the same sheet? But this is the second question, just to know what is your feeling. But the first is that the pacemaker rate, the definitive pacemaker rate at the discharge was 15%. So it's high, but it's not as higher as we had with the first generation of self-expandable valves like Corval or other valves, Portico. So the question is if you think that the reason for this low number of pacemaker with the first generation valve is due to you were treating big proportion of bicuspid valve instead of the normal population that we treat here in Latin America or in Europe.
Thank you, Matias. I think this is a very good question. I think there might be there might be no difference between the pacemaker rates between China and Argentina. I think the reason why they have higher pacemaker rates after the procedure in VitaFlow trial, that's because most centers in the trial is in the learning curve, so they are very nervous about the patient even with 1 degree of AV block. So, and also in the trial they want to maintain very high survival rates, so to make sure the patient is no problem. So they implant more pacemaker, I think. Now, for all comers in our clinical practice, the pacemaker rates with VitaFlow, the first generation, I think is only 7%. So this is comparable, I think, to your center maybe. Yeah. And the second question, I think I like, the all-in-one technique, because I don't need to puncture another access for, the patients can be used, to the simplified and minimalist TAVR. I think it's very smooth with 24-inch sheets we usually use for the all-in-one artery technique. But the problem, we didn't use, the totally all-in-one, because, the wire in China is not recurved wire. It might be, for some patients, it might be difficult, to use the wire pacing during the procedure. Yeah.
Okay, Dr. Song. Just a brief question before hear the comments from Dr. Alex. Do you use normally the coplanar position, or have you been used the cusp overlap technique to minimize the incidence of the pacemaker for these patients?
Yeah, thank you, Professor Mangione. I think we started to use the overlapping view, to deploy the valve since 2019. And I think this is not the overlapping view, because we found in the right caudal view, the aortic was elongated, so we can easily, to find, the depths we want to put. So I think this makes the pacemaker rates even lower than before, and also we are more confident to deploy our valve. Yeah, thank you.
Dr. Alex, your comments, please.
Yes, Mangione, thank you. Dr. Song, I'm very impressed with the results. Congratulations. This is almost 40% of bicuspid. So in terms of proportion, this is the highest proportion of bicuspid that I haven't seen in any study. So excellent results with very complex anatomy, close to 9% STS. So I'm very, very impressed. But I have a couple of questions to you. And the first one, in your opinion, in terms of valve selection, what are the differentiation features of this valve of VitaFlow that you think is going to favor your patients? Is there anything in particularly that you like about this valve superior to the other valves that you have in the market, number one? And number two, I understood that this is a supraannular solution. So any data on valve-in-valve for this particular device? Thank you so much again.
Yeah, thank you. This is a very good question. Yeah, I think VitaFlow TAVR system, the most specific feature I mentioned is about the electronic mode. So we can deploy with a motorized handle, and also the valve is not very tough. So when we deploy the valve, it's always very stable, and I think this is very important for newcomers. So I think the new centers and the new operators will like this feature. What we're worried about, in China, the morphology of the TAVR valve, as aortic valve, we have more calcium, and we have the thickness in the leaflets. So we worry about is if the valve we didn't have the strong radial force, it might be a problem when we're facing the valve failure in the future. But when we perform the follow-up for VitaFlow, but there is no problem during the 4-year follow-up. So this is the first question. And the second question, the valve-in-valve rates in the VitaFlow study. I didn't check in the statistic data, but I remember the study was reported by Professor Ger before from Shanghai. The valve-in-valve rate is less than 10%. Yeah.
Hey, Dr. Zhang, we have to move on because we're a little late in time. So I'd like to invite Dr. Junjie Zhang. Dr. Junjie Zhang will share with us a live in a box TAVR case in type 0 of bicuspid aortic valve. Please, Dr. Zhang.
Thank you very much, Dr. Mangione. It's my great honor to participate in this special session. So my case is about VitaFlow for the treatment of type 0 BAV with severe calcification. So this was a 6'5" gentleman presented with exertional dyspnea for 1 year and worsened for 20 days. He has a comorbidity with a gastric cancer surgery 10 years ago. So after admitted, the NT-proBNP test will show significantly high, more than 6,000, with a normal EGFR. And the ECG shows sinus arrhythmia with a left bundle branch block. STS score was lower than 4%. It's a lower risk patient. So let me show you the echocardiography for this particular patient. So from the echocardiography, you can notice that this patient was a typical severe aortic stenosis with a mean gradient 78 and the estimated valve open area only 0.4 square centimeter with a reduced LV function 41%. So before the procedure, we do the CT analysis for this patient. So you can notice that it's a typical type 0 bicuspid valve with a severe calcification. So this is the aortic CT analysis. You can notice that in terms of aneurysm diameter, the value was 24.5 millimeter with a parameter 88 millimeter. And we also do the supraannular analysis, just as Dr. Song mentioned, for this particular case. So at the level of 8 millimeter over the aneurysm level, the mean diameter only 24.2 millimeter. In terms of the coronary occlusion risk, we can notice that although it's a bicuspid valve, and although the left main height is 60 millimeter, however, the leaflet length of the left coronary is longer. The length is 18. And also you can notice the calcification was more than 1,100. So it's a typical, I think, BAV patient with a severe calcification.
Dr. Zhang, I think we can make a little break now to return to the CT evaluation to hear some comments about the panelists, about these measurements in this type 0 bicuspid aortic stenosis. I'd like to hear, you can go back in your slides, please, to the CT, and I'd like to hear some comments from Dr. Alexandre and Dr. Matias about this CT, the calculation, if they use the supraannular calculation, the annular calculation, this grade of stenosis in this big bicuspid valve, type 0 bicuspid valve. Please, Doctor, let's start with Dr. Alexandre. Dr. Alexandre, your comments about the CT.
Well, it's well documented, and of course, Dr. Zhang is very experienced. And bicuspid valve is always a big challenge in terms of valve sizing, in terms of where we're going to deploy it. In this particular case, I think that the sinus dimension looks acceptable, but there's always a little bit of fear to close the coronary arteries. So my question to Dr. Zhang is, for instance, for the left coronary, which is 16, now with the leaflet length of 18, would you perform a pre-dilatation in this valve and give a dye injection to see if you're going to close the coronary?
That's a very important question. So according to the CT analysis, there is a risk of left main occlusion. So I fully agree with your suggestion. I will do the balloon dilation, and at the same time, I will do the senior to see the risk of coronary occlusion. Then make a decision to see whether protect the left coronary.
Dr. Matias, any comments?
I have not comments. Maybe we can move in the presentation, and then I will
in the final
make another comment. Yeah.
Perfect.
In honor of the time.
Okay, Dr. Zhang, I think you can go ahead.
Yeah, thank you for your questions. I will go ahead. And according to the CT analysis, so my decision for my strategy for this particular case, I will use a 24 millimeter balloon to do the pre-dilation. And at the same time, I will do the senior to see the risk of coronary occlusion. And also, according to the CT analysis, I will use a supraannular sizing. I will downsize the valve because according to the aneurysm measurement, I will choose 30 millimeter. However, after I measure the supraannular, I will downsize, use a 24 millimeter valve. And also, I will use coronary protection. So this is my procedure. You can see left panel is aorta angiogram, there you can notice the severe calcification, and I use a stiff wire with the support of AR2 diagnostic catheter to facilitate the wire cross into the left ventricular. Then, in terms of the coronary occlusion risk, I use a Gazilla and the balloon to protect the left main. So I use 24 balloon to do the predilation, and at the same time I do the cine to see the is there any risk of left coronary occlusion. Actually, it's okay for this particular case. Then after predilation, I inserted the VitaFlow 24 device. Actually, at that time in China, we only have the LandQuest wire. It's a non-pre-shipped wire. This wire can give a very strong support to facilitate the valve cross into the left ventricular. Then I will use air and the left and the right cusp overlapping view to position the valve. And consider regarding its downside the valve, so my position is quite high, only 2 millimeters below the aneurysm. So this is my deployment procedure with 108 BPM pacing. So I gradually deployed the 27 millimeter VitaFlow valve. You can notice that during the deployment, the valve is very stable. There is no diving.
It is retrievable, right, Dr. Zhang?
No, it's the first generation, non-retrievable.
Now retrievable, okay.
Yeah. So this is immediate result after valve deployment. Due to the severe calcification and the BAV, you can notice that there is a width of the deployed valve. So also at that time, the echo coefficient, the gradient more than 20. So I decided to the post dilation with a 24 millimeter balloon with 2 times. Even 2 times post dilation with a 24 balloon, the gradient is still a little high, more than 10 millimeter. So finally, I make a decision to use a big size balloon, 26 big size balloon to do the post dilation again. So at this time, you can notice the stem frame was fully open. So this is the final result. You can notice that there is there is a very trace regurgitation, and also the gradient was reduced into less than 10 millimeter mercury. This is echocardiography show after 24 hours of the procedure. The mean gradient reduced to 9 millimeter mercury, and also the LVEF was increased from 41 pre-procedure to 58%. Now, and for this kind of patient, we routinely do the angio to the echo and the CT follow-up at 6 months. This is a 6 months echo follow-up. You can compare the pre-procedure and the 6 months post-procedure. The LV function was improved significantly. And the measurement, you can notice that the mean gradient was 11 millimeter mercury, and with the increased LVEF 72%. This was a CT follow-up at 6 months. From the CT performance, you can notice that the stem frequency was well post and expansion. So this is compare the pre-procedure CT analysis and the 6 months post-procedure CT analysis. You also can notice the calcium refract by the stem frame. And also we do the analysis, the parameter at the significantly calcified aortic lesions. The parameter was 79, and the diameter, mean diameter was 24 and 25 millimeter. From this view, you can see, I think this valve, the radial force is quite good. So take-home messages. I think bicuspid valve stenosis with a severe calcification may be treated with good success if we can do the CT measurement accurately. Superaneurysm measurement in combined with conventional annular measurement might optimize the pre-intervention evaluation of the patient. For this particular case, I choose superaneurysm sizing for this patient. Self-expandable TAVR processes such as the VitaFlow valve may be a good solution to accommodate BAV anatomy. Thanks for your attention.
Thanks, Dr. Zhang, for this very interesting case of a bicuspid valve. This technique to perform predilation with angio in cases when possibility of coronary occlusion, it's a very useful technique to check if there is or not chance for a coronary occlusion. Also, I'd like to hear the final comments of this session from Dr. Matias and Dr. Alexandre. I will start with Dr. Matias. Dr. Matias, please feel free to make your final comments.
Thank you, José. I would like to congratulate for this case. My comment is that there is not devices designed for treat this type of anatomy that we have seen in this case. So I feel, and I had the opportunity today to participate in the first VitaFlow case in Argentina. I feel that VitaFlow came with 3 main features. The first one is the radial force. And for sure, if we need high radial force, this is maybe the device to take in our minds, first of all, because today I touch myself the valve, and the radial force is really, really strong. It's very high. So for this type of anatomy, I think that this valve will have a big role. The second feature that I feel that this valve has solved very well is the sealing, because the skirt is so nice, it's very nice. If you see all the cases that we have seen, the sealing is not an issue. The leak, the paravalvular leak is less than 1 or 2% in 30 days. So this is another important feature. And the last feature that I think that is very important and will be nice for the new implanters is the motorized system. It's very stable. It's very stable, and also you don't need to pull and push. You put the wire on the ventricle, in the apex of the ventricle, and then you focus in the landmark to deliver the system, and then you press, you click the button step by step, and the delivery is very stable. So these 3 features, I think that will be the main feature of the valve and the target for patient selections.
Okay, let's finish with the comments with Dr. Alexandre. Dr. Alexandre, please, your final comments about this case.
Thank you, Mangione. I was also very impressed with both presentations. I'm very happy to see new kids on the block, right, coming to help us in terms of valve selection, in terms of competing for better prices, because at the end of the day, we have to benefit more patients. and we still have restrictions in terms of cost, in terms of being able to make these devices available for the vast majority of our population. So thank you so much for MicroPort, for the physicians who are really involved with this important research. I think we're going to benefit a lot from new solutions and new devices that can help our patients. Mangione, thank you also for your excellent presidency for SOLACI for the past year in a difficult year. And again, to our friends from China that soon will be able to visit us.
Okay, thank you, Dr. Alexandre, for your words about my president. Thank you. It was really a difficult time, but I tried to do my best. Okay, let's close this section. I think it was a very interesting session, another device in the marketing to help us to treat these patients with severe aortic stenosis. So I'd like to thank MicroPort again for this nice invitation to be here with Dr. Zhang, Dr. Song, Dr. Alexandra, and Matias and Alexandre. Okay, thank you very much, and have a good night for everybody. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Thank you all.
Thank you all. Thank you.